of the minutes of July 22nd. Is there a move to approve?
So move.
Second.
All right, is any discussion?
Nope.
All in favor, say aye.
Aye.
Aye, all right, that's approved as read. Required approvals, is there anything that anybody wishes to pull out of that? If not, then go ahead and please someone make a motion to approve.
So move.
So move.
Second.
All right, Mari moved and Case seconded. Any discussion? All in favor, say aye.
Aye.
Aye. Approvals are approved. So we'll go right into our patient advocate report now with Jackie Levin, our patient advocate. Jackie, are you there?
Hi there, I am here.
Okay.
Hello. Welcome, I'm glad to be here. I am giving you the data from our second quarter. So I think I have to take control. I can do that and get started here. So this is what we'll be going through: the responsiveness to our patient feedback, the distribution of the provider concerns, trends by area, and the other activities that we are involved in the patient advocate office. And a quick snapshot of our data from the second quarter is our average time to close was 18 days. Only 2 were over our 30-day expected and desired closure date. We've had an average closure time of acknowledgement from the time we received the call to the time of getting our formal acknowledgement letters out, 3.5 days. This quarter, we've had 39 concerns, and our patient navigation calls were 56. So we'll go into that, looking at this over time. So as you can see, the second quarter, we had a lot fewer contacts with patients, and one of the reasons is we had a lot fewer patients in the hospital. They were not going to the clinics. So there were less calls to us, and our navigation calls went up. Many of those were about accessing COVID information, and this is just again our the blue and the orange are regarding our average days to acknowledgement and average days to closure. So those stay relatively stable.
Jackie, may I interrupt just for a
Sure.
second? Could you explain what the navigation calls are?
Yes. So these are calls that are not formal patient complaint calls. So sometimes people feel that, well, we have a lot of now transgender navigation calls. So they're wondering who they can go to for a provider. We have new patients who are also looking for recommendations of who to see. Some patients were not satisfied with the new physician they got from the transfer of somebody retiring or somebody leaving. So they're looking for that kind of help. Others are not necessarily about quality of care, they're about bills. Sometimes if they've been sent to us, we still work them through. So they're not formal patient grievance complaint about a quality of care issue.
Thank you.
Yeah. So here's our emergency department, primary care, and express clinic concern data per 1,000 visits. And so I just wanted to, the percent differences I was looking at as they were going down from the last quarter. The primary care went down 25%. The went up 25% from last quarter. Maybe I made a mistake there. Express clinics went down 15%. The emergency department went down 24%. So this is, I mean, but the volume, the raw data is so small that I don't really know that that makes much of a difference. I just was curious myself about the change. I'm going to give you some trend lines. So, and breaking this down a little bit because it's a very busy slide, but just to give you again in one screen a snapshot of the areas that we're tracking specifically by service area. So when we look at our the primary care clinics, is that my, yeah, the clinics, we're looking at a slight, a trend line going down. For the specialty clinics, it's also a slight trend going down. It's just very interesting to see sort of the bumpy rides places get throughout the different quarters, but essentially it's nice to see a trend line. Joe had asked for that at another meeting, and so I thought I would bring that here. Again, the Express Clinic, just a slight trend up. The emergency department trending downward. Our ACU basically pretty steady in terms of its trend line. And the other here are all the kind of different places that don't fit into those other categories. And this is includes registration. This includes, as I said, surgery. It includes diagnostic imaging, the lab. And I would just say in this area, one of the reasons for this particular uptick in Q2 is our new registration screening process. So we had a new process to put in place. There was nothing, in place before that people could model. We had a lot of new staff members for that role coming on board at the same time. Our community members were anxious. So there was a lot. They were great. They provided a lot of information for us on how to follow through and provide training for our front end registration screening staff, for our spacing of people, just a lot of different people giving calls around that process. I haven't received many recently, although I did get someone today who heard from a friend of hers that the screening station was inside the building. And in her mind, it was outside the building. And this set up an alarm bell for her. She's coming in September for a dermatology appointment. So I just went through the process that people are masked when they arrive. Our screeners are masked. They don't get past that first few steps into the building. So hope she felt reassured.
Yeah, Jackie, this is Mike. I mean, right now, the notion of universal masking and temperature checks as you are entering the building seems like the norm. But we were kind of on the leading edge of doing that when we made the decision that everyone has to mask up. And my hunch, because I know that our staff felt the brunt of some community members who hadn't established that norm up to that point. So I suspect they probably represent some of that uptick. And then secondly, when we went to the temperature screening station, that was also kind of right when it was beginning to be a recommended best practice. And due to the delay and just the invasive nature of that, there were a lot of complaints, kind of sometimes not really polite complaints to our staff. So I would not be surprised if they represent some of that uptick too. So some of that probably is just the wake left behind and the turbulence encountered when you are establishing new social norms, because the notion of not wearing a mask now seems silly. But I tell you what, 2-3 months ago, when we said if you're not masked up, you can't come in, it did create some consternation with some of our patients.
Absolutely, absolutely. And I think just over the overall anxiety people are carrying brings that forward for them. Yeah, were there other comments or questions?
That makes sense.
Yeah, I mean, also the people's image of what that even meant. Just like this person, I was really surprised. I was like, wow, this has been going on for quite some time now. And but she felt reassured, and and I think for the most part, people are falling into that normalcy of this process. Yeah. Okay, so where am I? Here's my cursor. Here are our trends by types of concern: care provider, staff attitude, service delivery, and access. And I did some trend lines there. I just did the top trend line, which is the care provider concerns, and then I break those out. So slight increase. As you can see, these are the particular issues: communication, treatment choice, treatment plan selection, skill competency, and diagnosis. And these are from raw data. It's not the percentage based. So it's just a nice to see also just in terms of communication, it's an overall trend down. Skill competency, especially, a little bit down, but essentially stable. The treatment choice has gone slightly down, and our treatment plan slightly up, and our diagnosis just slightly up. Any questions about that? All right, so here are our community feedback trends. As I was saying, that the people were, we started a masking team to begin to roll out certain things. And I have to say, the billboard of Mike is, I find every time I enter the building and I see that, I think it's you, Mike, first of all. I just kind of go, oh, there's Mike.
Yeah.
But it's really, I think it's such a valuable statement. I really do. I feel like it's your presence. You're the CEO, and you're making this request, and I just think it's a great reminder. So I really think it adds something of importance to that screening station. The folks at the entryway received some advanced training and support, and registration is getting. They've had to do some, when people go on breaks, sometimes there's less at the thing. It's unpredictable when there might be a rush. So they're looking at their scheduling and staffing from some patient concerns. The Patient Family Advisory Council has been meeting by video chats, and I asked them to review our new open notes process that we have. And this was one of our patient family advisors responding. The notes on my primary care visit are so helpful. I completely understand them. We talked about a lot of things, and it's helpful to be able to refer back to the details so I can follow up as discussed. Also, this person mentioned and made note of something. Also, the provider mentioned and made note of something from a specialist visit I had in January. It was something I hadn't remembered, and also is not in my after visit summary from that visit. Since she made notes of that, I can follow up and understand more about this particular issue. So I think that's exactly the kind of thing that we are looking for with our open notes process. I am part of that team, and it does seem that people are, there's not been a big push yet to make a big announcement. Providers are still getting used to this process, but I do think in the end it will be something very positive for everyone.
Jackie?
Mark, did you have a question?
Yes, could you explain open notes a little more fully, please?
Yeah, and certainly if anybody else wants to do that who might be more versed in it. But it's a portal via MyChart that patients can actually access their clinic notes, the actual clinic notes. The only notes that I understand that will not be accessed through this are the emergency department notes, potentially some behavioral health notes, and I'm not sure about the express clinic notes. Anybody want to leap in there? But it's the ability to just read your own note directly. So, I mean, it's hard to remember what your provider has said or all the things that they've made suggestions for. And in this case, a lot of times the providers are in their note, they're talking about other notes that they're reading from an emergency room visit or from orthopedics or something like that, and pulling that in as part of their decision making. So I think it's just really helpful. Or they might be mentioning something from a specialist outside of Jefferson Healthcare that they've gone and seen and having that referenced in the note. So I think this just is going to make patients have more information and have better follow through.
Thank you. Thanks.
Mm-hmm. You can use it now, just going to your MyChart on your app, on your phone app, and it will say after visit summary, or I forget what it says, but then it says notes. You click that and you're taken to your notes. Just a little celebration at the end here with our HEI Leader Award for 2020. We achieved 100%. We just were given the approval to use their logo. And our goal for this year is to do some frontline staff education and gender affirming care through Seattle Children's Gender Center for our primary care staff. We're having more non-binary, transgender, and queer youth come through, and that was a request by our primary care providers to get a little bit more training. So we're there. Let's see. Any questions?
Questions from anyone?
I don't have any.
Okay. Matt?
No questions. Excellent presentation as always.
Case?
Thank you.
Case, you're muted. I don't know if you can hear. Can you hear us, Case? Okay. Mari?
No more questions, and maybe he's trying out his phone thing he was going to do.
He might be. There is looks like a phone number on.
Nope, I'm still here. Thank you. Sorry. Excellent presentation, and as always, I'm so proud of how we deal with patient concerns.
Very good. And I agree with everything that was said, Jackie. Nice report. Thank you.
Thank you. Have a great afternoon.
Yes. And we'll go on to the quality report. Brandy Manuel, our Chief Patient Safety and Quality Officer. Brandy, are you there?
I am. Hi, everybody. Thanks for making some time to talk a little bit about patient safety and quality. And I agree, Jackie does a great job, Jackie and Amy, on guiding our patients through our healthcare system. All right, so we take a look. We're going to do a quick overview on our patient safety and quality goals. We'll take a deeper dive into stroke. We've had some new changes with regard to our stroke treatment here at Jefferson Healthcare, so we'll talk about those. And then we'll take a look at our service to kind of follow up with what Jackie had reported. And then we'll end by taking a look at our current projects. So looking at our overall performance on our strategic goals and initiatives, we did fairly well over the last month or so. We did have one catheter-associated urinary tract infection that was reported on a patient who was immunocompromised, unfortunately. And in looking at the medical record, there was good care documented, good rationale for having that catheter, and unfortunately ended up having a UTI or urinary tract infection that was treated, and the patient did fine subsequently. We have not had any cases of hospital-acquired C. diff. And our antimicrobial stewardship program continues to tick along with COVID right in the middle of our big ambulatory antimicrobial stewardship project. We took a pause, but last month we restarted that project with our providers and had kind of another kickoff meeting, and they're eager to get going again, and we're seeing some good data out of our express clinic. Our inpatient days of therapy continue to hold steady, and those are in most areas below target, except for the one antibiotic class that every other hospital in the state seems to be seeing the same increase in. And then we are continuing to avoid antibiotics for upper respiratory infection. We continue to do well with our core measure compliance, and we did unfortunately have one pretty serious event related to workplace violence. Our team has been taking a deep dive into this one incident, but we had a patient who presented to the emergency department and unfortunately harmed one of our staff members. The police were also involved, and the police officer who responded to that call, in addition to the sheriff's office and the Washington State Patrol, was also harmed in this event. So we are taking a deep dive into that to better understand sort of what led up to it and see if there were lessons learned that we might be able to move forward and change our system with.
How is our staff person?
Doing well. Fortunately, unfortunately, the police officer took most of the brunt of it. It could have been much, much worse, but it was they were kicked in the face, so it wasn't a small event. And then our readmission rates continue to be below both state and national averages. All right, so our stroke performance report, what we're seeing here is our stroke composite score for 2020 as compared to Washington hospitals, as well as our critical access hospital benchmark. You can see that we're doing pretty well. We're the dark blue line, and overall we're doing well. If we look at what is behind that blue line, it's all of these indicators. So all of these roll up into this one composite score, and Jefferson Healthcare historically has done very well with this. On August 11th, we switched our telestroke program from Swedish to Providence. And as part of that work, our emergency department did 4 drills to kind of prepare and identify any issues. And in that process, they came up with some really great things to kind of work on and fix. And so there's a whole renewed energy around taking care of our stroke patients. They're doing an active performance improvement project on our time to CT for stroke patients, and doing time studies this month to kind of really identify any opportunity to trim down the time that it takes for a patient to get from the door to the CT to getting the treatment that they need. But partnering with Providence really opens up the door for us to have greater access to even more providers 24 hours a day, 7 days a week. If a patient comes here for treatment of a suspected stroke, within minutes, we can actually less than minutes, within a minute, we can connect with a stroke specialist at any one of the Providence hospitals that we have credentialed providers through. And they will partner with our emergency department physicians to diagnose and treat those patients and get them transferred as quickly as possible. In doing those drills, we did 2 drills on night shift and 2 during the day shift. And we found a couple of great opportunities, including the way that the images get pushed over. And then also we found that the new phones that we had installed, which are amazing, had the number to Swedish programmed in them and not Providence. So we were able to make some good systems changes there. So really great work by our emergency department team. And just a couple of weeks ago, we got word that we had been awarded with the Stroke Gold Plus Award. And this year, they had an additional distinction, which was a Type 2 Diabetes Honor Roll Achievement Award. So that composite score that we've shown month after month and quarter after quarter is paying off in dividends for our patient, but also is recognized outside of our hospital as well. And moving into the patient experience, we have seen a little bit of feedback come from our patients. I think in this post-COVID world, as patients try to navigate, and Jackie alluded to this a little bit, it can be hard to find where patients need to go. Also, there was a delay for some folks in being able to get what seemed like on the surface an elective procedure. But at the end of the day, a delay in these tests or screenings or elective visits can have longer term consequences. And so we're seeing a few of those comments trickle in, and being mindful of those. Also things like it's just hard for some of our patients to hear with all of us being masked all the time. So understanding that we need to be masked, it's important for their safety and for ours, but also it really gives us pause to think about how we communicate with our patients and how we might use other tools. The open note that Jackie just talked about is a great way of sort of augmenting our communication to make sure that patients are understanding what it is that we're asking them to do. So, but overall, the comments that we're seeing continue to be positive. What you see here is our home health team, and we had some great feedback on our home health team, including this is the best I've ever been treated. So great work there. And continuing down that path, looking at the patient perspective, and you heard Jen and Dr. Butterfield just a little while ago talk about the dyad model in our medical group, and these comments come from our clinics, from the surgical associates to primary care to specialty clinics. Really great feedback from our patients, and calling out the good work of our physicians. So continuing to serve our community. And then just to close the loop on accreditation, last time we talked a little bit about some of our opportunities for improvement that our friends at the DNB found for us. So they have notified us that they have accepted our corrective action plan just this week, and they sent us our certificate of accreditation. So they, because of COVID, they had to postpone our visit, which is why the date looks a little bit funny. So we were actually due for our recertification May 26th, and they didn't come until much later. And so the certificate was backdated to May 26th. We will be submitting our evidence of standards compliance in the next couple of weeks for the NC1s that they found. And then we'll continue to monitor the effectiveness of our quality management system. Also, next week, we plan on seeing them again. So they will be here for about a 1.5-day survey to look at our infection prevention programs. And Laura does a great job with that program. And we have fully vetted it and gone through all of the standards and feel good about where we stand. Also recognizing and hoping that we get some feedback about things that we can do better, because that's, after all, why we partner with them. And then also expected in the next couple of weeks, new critical access standards are expected. I don't have a glimpse into what those will look like just yet, but I do anticipate there will be some changes to the infection control standards. And then just taking a look at our current projects, Jen mentioned the project that she's leading in closing the referrals loops, really important from a patient safety perspective. It's also recognized within our MIPS score. So as she pointed out, we did really well. One of the areas where we had some opportunity for improvement was in promoting interoperability. And one piece of that is closing the referrals loop. So this is really great work for our patients and for our providers. Also kind of looking at the CT time that I mentioned earlier, looking at surgical safety, really focusing on workplace violence prevention, always focusing on that, but certainly trying to drill down on our most recent incident, and then continuing with our ongoing quality work. and completing the barcode medication administration pilot. We're extending that into the second ambulatory site and are hoping to have it fully launched by the end of the year. And we are also launching a medication safety team in partnership with Dr. Harris and Lanny. And that team will report to our Executive Quality Council as well as our Pharmacy and Therapeutics Committee, which is a physician-led committee. Are there any questions?
Any questions for Brandy? I have a comment. I thought it was really telling that one of the patients applauded us for having the staff all make them feel happy working together and providing a happy environment for the patient. I think that is so important, and it speaks a lot about our organization. That patient recognized that. Excellent report. Excellent work.
I do have one comment, Jill.
Yes.
I just want to say that to continue to do the kind of certification that the staff is going through under the conditions that currently exist, with the need for social distancing and masking and testing and all of the disruptions that have happened to our normal way of doing things, to be able to go through all of that and continue to meet the standards is just remarkable. I mean, I'm just totally impressed.
We have some great teams hard at work. Thanks.
All right. Anybody else? Well, thank you, Brandy, for an excellent report. Okay, Mike Glenn, our CEO, with an administration report.
Right, and so I echo Case's comments about the quality and the accreditation work that Brandy leads, and like the DNV and the DOH and many of those certification surveys are kind of mandatory or required. I think in the next week or so, we have invited DNV to come to Jefferson Healthcare to do an infection control accreditation survey. So Brandy can't get enough of this fund for the required accreditation surveys. She seeks them out. But actually, we thought that because of all the work that we were doing around infection control with respect to COVID, which frankly, I don't think it's going to go away. The increased attention to keeping our patients safe, that we thought this was a great time to go through that process. So Brandy, is that like in the next couple of weeks, did I see?
That is next week.
Next week. Yikes.
Yeah. And you bet I'll be phoning a friend or two to join in the fun.
But when we get through that, we'll have another another badge, be certified by DNV for infection control. So it's work worth doing. Okay.
Can I say something, Jill? I think if we're doing the work, we should get acknowledgement for it. We, Jefferson Healthcare, and everybody who works so hard. So if we're doing the work, we get acknowledgement and as many attaboys as we can.
Yeah, and I think Brandy heard that outfit out west got this certification, so she concluded we needed to get it too.
We're going to have to build another interior wall of awards.
Yep, I think you're right. Okay, so testing, and I actually did a quick lookup of the number of county tests that Willie Benson, the EOC report, and that number is about 6,200, 6,250. So basically just shy of 95% Case, to answer your question, or whoever answered that question, what percentage of tests we do? We do about 95% according to these numbers and the numbers that the county reports. And the public health department does have their own lab. So every once in a while, particularly at the beginning, when we were trying to figure out which laboratory had the best turnaround time, we were sending more tests through public health. And while we're comfortable assuming this responsibility, we are also maybe even more comfortable with the notion of other laboratories doing this work too. But the percent positive continues to climb up, but the positivity rate stays about the same at just over 1%. And Dr. Locke alluded to the possibility of an outbreak related to some gatherings at Lake Tarbu. So we did a boatload of tests through their contact tracing Saturday and Sunday, and most of those results came back yesterday, and were all negative. So the bad news is that the reason that those tests occurred is because there was some gatherings of lots of people and not following social distancing. The good news is probably because the low community prevalence, none of those tracings came back positive. So we're very pleased about that. And under employee tests, we did have kind of our first occupational transmitted positive that we believe occurred a week ago yesterday. Became symptomatic Friday. We learned of it on Saturday and tested on Sunday morning, and results came out positive. And as I mentioned to you, we then identified all of the Jefferson Healthcare employees that had come in contact either with that patient or with that employee, and arranged for them to get tested with our rapid turnaround test within the hospital. And I think that the total number was 37, and all of those tests came back negative. And our goal was to have those tests come back prior to those employees seeing patients again. And because it was a Sunday, we were able to do that. We were working in close consultation with Dr. Locke and Public Health, and they sort of advised us on how to arrange the testing and the communication with patients. And they also recommend that because the testing was so early in the in sort of the incubation period, for lack of a better term, to do some testing again, just to be sure. So we are working a plan to do that as well. But the good news is that all of our employees were wearing appropriate PPE and following appropriate infection control protocols. So the fact that all these tests came back negative, while a great relief, was not a surprise necessarily. And we communicated that via an all-user email Monday morning. Okay, next slide. So our PPE, I think it's fair to say we just have this figured out, that Kelly O'Connell is Kelly's actually sitting on a statewide panel now, as the Washington State Hospital Association is developing sort of a track that does not include the State Department of Health and the county players, so that the PPE could be managed directly with the hospitals. And Kelly was selected for that committee because of her great work. But really, what you should look for with this graph is chart is the salmon colored line, the Jefferson Healthcare COVID surge stockpile. That number represents 21 days of extraordinarily busy patient care. So 25 really sick patients and 50 patients going through the emergency department. So to give you a perspective of our total PPE inventory, say for 80,000, and I think that's 81,000. We almost have what is that? Almost 60 days. So two months, 50-ish days of procedure masks here at the hospital, and so we're very comfortable with our PPE inventories. We never have to make a decision on procedure mask, N95 mask, reuse, not reuse, based on inventory. It's all based on CDC and World Health Organization and public health recommendations, based on science and based on what our employees feel they need to keep safe. And that's just a great place to be at, because we weren't at that place months ago, and I'm not sure all hospitals are, but it's nice to not have to worry that the mask you're wearing today to take care of a non-COVID patient may be the mask you need tomorrow to take care of a COVID patient. Next. A couple of volume slides. The primary care variance target visit, again, that 89% represents the percent of our budgeted numbers. August is a high vacation month, so we encourage providers and staff alike to get out and enjoy the weather and the scenery during this month. It's a little more fun to go hiking in August than it is in February. It's not uncommon to be running at 90% of budget in August. Specialty clinics busier. We were hit with vacations of second week of August, but not so much the third week, and volumes popped up to 98% of target. Next, please. And these are our surgical volumes. Big driver for the total revenue picture. And we're at 95% after 76%. And in case I was listening to a public health board meeting a month ago or so, and you were commenting on how things were bouncing back at the hospital, and had mentioned that surgery volumes were growing, and that was contributing to our improved financial position. And one of your colleagues made the comment like that was not necessarily a positive thing, the fact that more residents needed surgery. And I think you gave an appropriate comment, but I think the best way to answer that is our surgery growth is a reflection of fewer people leaving the community for surgery. It's not the total number of surgeries for our community hasn't grown, certainly not any faster than population, but nearly all of the surgical procedure growth at Jefferson Healthcare is the result of people not having to go to Bremerton or Seattle any longer. So it's a huge convenience to our residents. It's an economic driver for Jefferson Healthcare and for the families of the employees that we can put to work. So that might, if that comment is made again, because it's not necessarily intuitive. You would think that a growth in surgery means that's not a good thing. More people need it. But our market share has been growing and continues to grow, and I think the fact that we can take care of more people locally is a good thing.
I will certainly add that to my future comments.
All right. Next slide, please. And this is the graph that charts Express Clinic and Emergency Department visits. Again, the Express Clinic in tan, the Emergency Department in blue. As you sort of track the Emergency Department visit, it's climbing back, particularly the first couple or the second and third week of July. Those numbers look very similar to pre-COVID numbers. The Express Clinic numbers, interestingly, continue to lag, and I don't have an explanation for that. We are keeping that staff the same because it is such an effective pop-off valve for when the emergency department gets real busy. Next slide, please. All right, and next slide. So about a year ago, Jefferson Healthcare, through the Washington Rural Healthcare Collaborative, pulled all of the hospitals together to bid out our retirement plan administrative services. And like most purchase services, size of the order dictates size of the discount. So by combining the weight of all of our pension and deferred compensation plans, so still independent and managed at Jefferson Healthcare, but by cobbling them together for the purpose of seeking an RFP, we were able to negotiate a better deal on administrative and carrying costs for all employee participants in the plan. And if you've ever ran the numbers on what tenths of percentages of administrative costs, either it being a load on a mutual fund or just a cost to administrate a retirement plan over the course of 15, 20, 30 years, it can be $20,000, $30,000. So we thought that there was opportunity to provide better services for our employees and to save them some money. So basically we have two plans. We've got the 401A plan, which is the large, entirely employee-funded plan. It's commonly referred to as our pension plan. Employees are eligible after 2 years of service, and they are fully vested, which is a nice thing. In many organizations, Providence and Valley, the two hospitals that I was at before this one, you had to work there for 7 years before you were vested. Here it's 2 years, 100% vested. And then in addition to that employer funded plan, we have our 457B plans, which are deferred compensation plans. So they are largely funded by employees, where employees defer part of their compensation into these plans, but they are run by the plan administrator. And right now that's John Hancock. Next slide. So the goal of this process was to basically find a better mousetrap by pooling all of our dollars together. See if we could attract ideally a non-proprietary player. John Hancock has John Hancock funds, and most of the fund options made available to our employees, or certainly a large footprint of those fund options were John Hancock funds. And we certainly didn't have some of the larger fund families like Vanguard available to us. To a great extent. So we wanted to have an open platform to invite more funds into, make them available to our employees. We wanted there to be less of a proprietary influence. So investment options that weren't managed by the service provider. Reduce the cost of the plan to participants. Again, even if it was just by tenth of percentages, we were looking to do that and simplify the process and the structure to make for a better retirement saving process for our employees. Because we have defined contribution plans. Which means we make a contribution as a percentage of your income to these plans, and then the employees are responsible to manage those dollars, and whatever that amount is their pension. We don't have a defined benefit plan, which was pension plans of the past, where you would be guaranteed, say, 70% of your final salary. So I think the mechanism of managing your retirement is more important now, because however effective you are at doing that has a significant bearing on your retirement. Next slide, please. So to kind of cut to the chase, the collaborative chose to go with Nationwide, and Nationwide is a big pension plan broker, if you will, that provides administrative services significantly less. So advisor fee, record keeping, and administration will be less for all of our participants. But more importantly, they have a much broader array of investment instruments and index funds to offer our employees. So, a proprietary S&P 500 index fund might be at priced at 0.5 of a hundredth of a percent, where a Vanguard S&P 500 index fund might be 0.2 1/100th of a percent. And just by virtue of Vanguard's business model and how big they are. So our employees will now have the opportunity to move from a proprietary S&P 500 index fund to, say, a Vanguard one, and save money. I think that's where the savings will truly be discovered over the course of a career. Next slide, please. Value-added services. They provided legal counsel for us to make sure that the retirement board, which I think Hillary and I and Hillary, Caitlin, and I represent the retirement board plan board for Jefferson Healthcare, and we have a fiduciary responsibility to make sure that the plan is well managed, appropriately managed, and fair-minded. They will also provide consultants to help us with the management of the different investment opportunities and instruments. And the record keeping and the custodian services for all of the regulations that you can imagine are necessary. So we feel pretty good about this opportunity. It's been something we wanted to do for quite some time. I've been involved in 2 or 3 of those processes, and just by virtue of going out to market, you get a better deal for your employees. Because everybody's forced to sharpen their pencil, and it's really less about the administrative costs that you save and more about the 2 to 3x more investment instrument opportunities that you have. So we feel really good about the process through the collaborative and making this available to our employees. So prior to making the decision, we had these open invitations for anybody who wanted to come and talk to Human Resources to ask questions or share any concerns. And every person who interacted with Human Resources when they learned about this new platform were really excited, mostly because now you can make your Jefferson Healthcare investment portfolio look more like your non-Jefferson Healthcare investment portfolio, because many of those big fund families are now available to us. So we intend to move forward with this along with the other collaborative hospitals and go live in January, and there will be resources available for our employees to help with the transition. But I think it's going to be a great thing. Okay, next slide. Another exciting announcement is we may have mentioned a month ago or so that Dr. Parker had submitted a request for a grant to the Department of Commerce for a childcare partnership planning process, and we were awarded the grant. It's Jefferson Healthcare, Peninsula College, and the YMCA. It's $91,000. And it's for the purpose of funding a planning process to see if we can work with Peninsula College and or the Y to stand up a desperately needed childcare center here in Jefferson County, and preferably Port Townsend. That for those of you that may know, the Peninsula College runs an early childhood education program in Port Angeles, and as part of that program, they offer childcare services mostly to their own employees, but to the community. So it's not only providing childcare services, but it's part of that didactic programming. We have had a couple of meetings with them asking if they would be interested in extending that service and program to Jefferson County, and they are. So that's why they are part of this planning process. But if that proves to be too burdensome or unfeasible, we can veer off to work with other partners. But it's a great opportunity and another feather in Dr. Parker's cap. Next. In addition to that, childcare access to childcare services is, I mean, it's always a challenge for Jefferson County, but right now it's a crisis because we have employees saying that if I can't find childcare, I can't come to work. We aren't really in a position where we could sit back and wait for the child care community to figure this out. We are partnering with the YMCA and allocating up to $5,000 a month to mostly subsidize the cost of childcare services to essential healthcare employees, which will largely be Jefferson Healthcare employees, but we didn't want to call that out specifically, to provide some relief and some direction for our employees. So this is something that it's kind of bittersweet. I mean, it feels good to be able to do this for our employees, and there's some enlightened self-interest behind this. Because we're running a survey right now asking our employees, how many of you are running into childcare issues and how large of a crisis is this? And we've gotten 60 response back, and many of them saying, it truly is, whether I find affordable childcare is whether I can keep working for you or not. So this is really something we don't feel we have a choice in doing, and I'll just say I wish we didn't have to do this, because we have other areas where we need to be focused on and allocate scarce resources. But this is where we're at. So the good news is that Wendy Burt from the YMCA stepped up and has been a great partner, is standing up childcare capacity at the new elementary school, and also developing a plan to provide more childcare at Chimicum. But I guess the last thing I'll say on this is that this is a community problem that is going to continue to be a problem, and is screaming for a community solution. So hopefully at this planning process, which we've been in touch with the city and the county, we'll come up with something longer term and help other essential employees, families manage through this. But kudos to the Y, kudos to Molly for being instrumental in putting this together, and John French as well. Next slide. And then just a couple of real quick updates. We're very close to the finalizing the sort of master plan draft update. We're going to try to get in front of commissioners in the next month or so to sort of show you where we are at and seek your feedback. Certainly before we go, I make a presentation either in September, but likely in October. And the same is true with the strategic plan refresh process. We started that, had a couple of meetings with Katie Holmes, and then COVID hit. So we just suspended that work, and that work is resuming in I think as soon as this Friday. But again, it's refreshing using the template of our existing strategic plan, but just drilling down on our goals and objectives to make sure that they are timely. And then lastly, and I think Hillary's going to speak a little bit more about this, but our new 128 slice CT scanner has been installed. And I think that this is a big deal for lots of reasons, but when I was at Valley just 11 years ago or so, Valley installed the first 128 slice CT scanner on the West Coast in their new emergency department facility. And then fast forward 10 years later, a small critical access hospital on the North Olympic Peninsula is installing one. So I think that's probably says more about the democratization of technology than anything else, but I still think it's pretty cool. And then secondly, I remember when buying a used CT scan was a big dang deal for us. So it's I want to make sure that we call this out and recognize it as a pretty a great introduction of advanced technology for our community. It's faster, it's got a wider bore, can accommodate bariatric patients, and has far more radioactivity sensitivity. So a patient only gets as much radiation as the scan requires. So a great piece of technology, but again, I think Hillary's going to speak a little bit more about that. All right, that concludes my presentation. Happy to answer any questions that you may have.
I had to. Is there an echo?
Yes, there is an echo.
I don't know why that's happening. I guess it's okay now.
Yeah.
I was going to say that's the first time I've seen new is in any connection with any CT scanner that we bought.
Yeah, we were buying the certified pre-owned version before this one.
So
if I may just say something regarding the childcare, this has been an ongoing problem in certainly in Port Townsend and probably in the whole of Jefferson County and Ochimicum and other places where it's very difficult when you have two parents working of necessity, and childcare has been, I've suffered that problem when my son was young, and it's gotten worse over these this last decade, I think.
Yeah, it's a problem that's grown to a crisis that is just screaming for a community response and a community answer. And I've talked with John Morrow about it, and he's interested in participating in a solution, as is Philip Morley. But man, the major employers just have to all go together to figure this out.
I applaud you for taking the lead on it for us.
Yes.
Well,
And
It's in
particularly,
my self-interest, truly, that we would lose a big percentage of our MAs. It's like we are feeling the sharp edge of the spear of the crisis, and we really don't have any other choice.
and particularly, if we want to keep and bring more people in, the younger generation in, which are necessary to keep this community vibrant, we need to be able to support them and their work and their families. And it really is a problem that I think everybody needs to address. The local industries and the local, the local agencies with the city, the county, and us, and other larger enterprises, because it is a huge problem. And I like Jill said, I really thank you, even though it might be a necessity, for taking the lead once again and trying to help the community move forward.
Are there any other comments, questions? Matt?
Yeah. I have a question about the employee that got infected with COVID. Have we done a root cause analysis of the infection? Have we learned something from that? Do we think it is preventable, the circumstances in which the employee was exposed?
Well, that work is going on now, both with our contact tracing and the public health department. I think if you consider Jefferson Healthcare as the intersection of every COVID positive patient in Jefferson County, either through the drive-through station, the respiratory station, the emergency department, express clinic, and this is, I don't think anybody, I don't think it's possible to not have this occur. I mean, that's just the reality of it. The short answer to your question is yes, but that's the insidiousness of this, and it's the constant drumbeat that our employees are managing. You put on your PPE right 99% of the time, or you follow all infection control protocols 99% of the time. There's just no way that this can still happen. So the short answer to your question is yes, but the frustrating response to your question is, it's the madness of what we're dealing with now, and I think it's the irritation that you see from providers, from healthcare employees and providers, when there's lack of compliance with best practices, that keep this going, because many of them feel that it's only a matter of time if this thing drags on 6, 7, 8, 9 months.
I'd like to second what Mike just said. When you realize that the current understanding is that 10 to 20% of the spread, 10 to 20% of people who get the infection and spread it actually do the vast majority of the spreading of the infection. These are the super spreaders, and some people, when they have the infection, are just remarkably capable of spreading this virus in a very dramatic way. And when you think of the outbreak of infections at Harrison Hospital that was reported recently with, I believe, 30 employees and 20 patients, it just proves what Mike said, it's insidious, how this virus can just get into just about anywhere.
Can we know where in the hospital it happened? Do we know what part of our system the person got exposed?
Yes.
you not want to say that out loud, or I'm just curious where?
Well,
just so I know.
I think it's as I shared in my email to the board and all user emails, the emergency department.
Okay, right.
Jill, I have a few additional comments about COVID cases and testing. Would you rather I do that later under board reports, or?
Yes, let's do that under board reports, and then and I'll ask if anyone else, if you, Case or Bruce, have any other comments or questions.
No, I mean, I know what Matt's trying to say. I mean, and I hear what Mike's saying and what Case is saying, but you know, we have protocols, and we believe we're following all those protocols, and you know, so that with PPE, so somebody doesn't get exposed to where they're going to get it, you know. But I think Matt's wanting to make sure that, you know, that we didn't miss something, you know, either when they're taking off their PPE or, you know, on our procedures to just to make sure that we're keeping people just as safe as we can.
Yep.
Good point. All right. Thank you, Mike, very much for excellent report as usual. And thank you. And we will now go on to Hillary Whittington, our CAO and CFO, for the July finance report.
Great, thank you. A quick sound check, sound okay? Yes?
Yep, sounds
Okay.
good.
Great. And Alyssa, if I just tell you next, does that work?
Yes, that works.
Okay, perfect. We'll go to the next slide. We have July's finance report for you today. And before we get started, for the last few months, we've been talking about the Medicare accelerated payment program, so the loan from Medicare. And for the last 4 months or so, we've been saying that the payments would start in August. So I thought we would first inventory what we know, what we don't know, and our plan to navigate both. So the general background is, at the beginning of the pandemic, there was an opportunity for us to advance about 6 months, a little more, 125% of our last 6 months of payments from Medicare as a loan. And we took advantage of that program for most of our service lines, excluding home health and hospice. So what that meant was about 50 days of cash, or $18 million, was deposited into our account. We put that into our standard savings account, which my career to date was the largest check I've ever signed, and put it into the restricted board account, and it is sat there. The intent of the loan was to provide a cash bridge for low payments that may happen as a result of, at that time, tanking patient volumes. Because of other cash flows, including the CARES funding and payments from the Healthcare Authority on the 2014 to 2017 enhancement payments, we haven't needed the cash, and it's sat there. The original commitment is that after 120 days, the cash would be recouped by Medicare by not paying us what we would normally be paid for patient service until the loan was fully repaid. And there's been some flexibility on how long that could take, if it was 6 months without interest or a year, and there's been flexibility there. At this point, it sits as a year. However, it's been more than 120 days. Our payments have not started to be recouped. We're watching every day to see when or if any of our payments start to be affected. We have the option of sending the cash back. But until we know for sure that there wouldn't be any type of forgiveness on this loan, we are holding it, and we'll inventory probably every 3 to 4 weeks to see if we would like to send the cash back in a lump sum method all at once, or if we continue to, whether it's recouped or not recouped. I called Noridian, our intermediary for Medicare, just to learn more about the payment. It sounded like if they were getting checks in the mail, they were holding them in a pile rather than cashing them. And the process of recoupments hadn't started for those who even applied a couple of weeks before us. So we will keep you posted, but even if the payments, if the recoupments start, we are in an okay space when it comes to cash, and we'll look at that at the end of the finance report. But it's certainly on our radar. And when it comes to things that can become distracting, managing and monitoring all recoupments through Medicare could become really complicated and distract us from running the good revenue cycle, streamlined focus we have right now. In general, it could take up to, probably half of someone's job would be reconciling all of these payments or lack thereof. So if we can, we'd like to pay it back, but we don't want to risk a potential forgiveness of some or part of the loan in the meantime. So we have our eyes on it, but that is our current situation and strategy. Before we move on, are there any questions on this in particular? It's a lot of cash. All right, Alyssa, if we can move to the next. As Mike mentioned, we replaced our CT scanner, and this was a significant capital project, and we're incredibly pleased with both how the project went and the quality and execution of the plan overall. So the project took place most of July. The mobile arrived on July 8th, and we were scanning our first patient on the 28th. So we were about 2 days ahead of schedule. We intended to have the mobile up and running for at least 3 weeks, maybe 3 weeks and a couple of days. We also came in about $30,000 under budget. Our diagnostic imaging team did a great job. Everyone pulled together. We made sure that our patients were safe, received quality scans, and the process itself went well for our patients, or as well as it could, given that our patients were taking a different route through our building than typical. We didn't have any gap in service to our patients, and surprisingly enough, the period when our mobile was actually some of our busier days when it comes to volumes. A typical day is 15 to 20 scans, and one of the days in particular, we did 29 scans on our mobile. So we were quite busy, but the installation went well. Our volumes remained consistent. And as Mike said, this CT has some really great features. The table can now accommodate 600 pounds, so we're up. Previously, it was between 350 and 400 pounds. And we are working on both cardiac calcium scoring. We're doing our first scan tomorrow, and we're looking into some different metal artifact reduction so we can help folks with joint replacements and to have better scans than would be available previously. One of the bigger things is that we've added a different power source. One of the things that can trip a CT is flickering of power. And by adding a UPS, we can greatly reduce downtime. So it's fast, it's very quiet, and our downtime will be reduced significantly. So we are quite pleased. So while not necessarily a department to highlight, I think it brings together, as a department to highlight, but the facilities team did a wonderful job. The ED had a big role in making sure that the interim plan was streamlined. The providers did a great job responding, and the DI team, obviously. We'll move on. So as we look at July, I think for the next few months, this is probably more of a typical month that we will see. July, August, September. In general, October and November tend to be our busier months, and we tend to be a bit above budget. But in July, we didn't record any unusual or CARES or stimulus related funding. So this is a more accurate picture of what we will see, assuming patient volumes are about where they are now. So across different departments, you can see that certain departments are doing well compared to budget. If I look down toward the lab, dental clinic is a backup. Looking at the details, we were above budget in general surgery, or right at budget. Echo was quite a bit above budget, and CT was as well. And then there's some departments where, whether because of patient volumes or because of workflows or provider vacations, we were below budget. So the express clinic is in that category, mammo, and some of the specialty clinics where provider vacations really impact our volumes. But overall, the bigger fluctuations is what we tend to see over the summer, because so many departments are impacted by 1 or 2 people being out on well-deserved summer breaks. Move on to the income statement. Overall, this was a fairly close to budget revenue month and a fairly close to budget operating expenses month. So as I said, this is what we can expect the next few months to look like, assuming that we continue to see revenues that are close to budget. We were about 1% as an unfavorable budget variance on the revenue side. What that actually was 21% below budget for our inpatient volumes and 4% above budget on the outpatient side. Surgery, lab, pharmacy, hospice, and dermatology were the contributing departments where they were much busier than our budgeted volumes. We're being pretty careful and intentional with our revenue adjustments. With our volumes changing as much as they are and our revenues changing as much as they are, much more of our revenue adjustments are tied to our costs than our charges. So we need to do an expense review each month. So I expect bigger variations to budget because our expenses and our revenues aren't correlated quite as closely as they are when our volumes are more linear. But overall, we landed the month, when you consider the low other revenue from a decrease in dietary revenue, and we're still running below revenue in our retail pharmacy. So we were about 1.2 million below on the operating revenue side. And on the operating expenses side, we managed our salaries and wages to about 2% below budget, including somewhere between 15 and 20 employees that work on COVID-related activities. So screeners, running the respiratory evaluation station, and the drive-through. So some of that variance has to do with those with positions that we haven't filled in other departments, but we are continuing to be close to budget because of these additional COVID-related expenses. Employee benefits this month, we have about 200,000 of a workers' comp dividend in there, and we recorded that in July, though it relates to prior years. However, it's not, when we're notified of the dividend is when we record it from the financial statement perspective, as that's when we can, when it's determined collectible. So looking at total operating expenses, we were about 3% below our budget, landing the month with a $467,000 loss from operations. We recorded some donation revenue in the non-operating revenue section, about 160,000 of donations from the state and any other PPE donated from our community. We inventoried and valued all of the masks. We've received some resources from our community, and those were all valued and recorded along with the expense that as we've used them. So our change in net position this month is a loss of 368,000.
Hillary?
Yeah.
So it doesn't show on that sheet that you have up there, but on the one that was in our packet, as for supplies, that we're like $500,000 over budget for the month for supplies, and yet we're under for the year. Budget, yeah.
Yeah, most of the supplies variance has to do with pharmacy, and that's where a lot of the revenue comes in as well. depending on the months of pharmacy and specifically what type of infusions are being provided, those drugs can add up quite quickly. And also, we don't do a full inventory of our pharmaceuticals every month. So as we put supplies up on the floor, that can fluctuate both the supplies number.
Okay.
So it was a big expense month in terms of refilling the pharmaceuticals and expensive drug months for many of our cancer patients.
Okay, thanks.
And when we look at the months ahead, our intent and our commitment is that we keep our teams intact as much as we can. And what that means is we are encouraging folks to take PTO, but we aren't taking drastic measures like you read about in the newspaper, because us retaining our employees is incredibly important for our overall sustainability going forward. But in months like August, September, and I bet even October this year, as folks are trying to take vacations, and where many people did not take time away during traditional spring break time this year, we're expecting that we'll be a bit below budget on the revenue side, 3, 4, 5%. This month we're trending about 8% below budget, and for our expenses to be fairly close to budget. So we are expecting a loss in many of the upcoming months. Some of that will be offset by a cost report calculation at the end of the year, but this month as a loss is not atypical for what we will see depending on the behaviors of both our patients and our staff in the upcoming months. Our eyes have been on cash, and I'll show you the days cash on hand number in a minute, but we are intentionally focused on retention and ensuring that our model doesn't have longer term consequences because we're trying to save a small amount of money now. So we're cutting expenses where we can. We're being very cautious with vendors and slowing down our capital expenses, but I don't expect the salaries and wages number to be much below budget, especially given that we're employing virtually three new service lines, being the respiratory evaluation station, the screeners, and the drive-through station.
Excuse me, Hillary.
Yeah.
Could you say again how many employees you estimate are involved in specific COVID-19 treatment or screening activities? What is the FTE? I think you said 20 to 30?
It's between 15 and 20, depending on the day, and depending on how we staff. And it's the respiratory evaluation station staffing changes based on the day. And some days the clinic is open, and other days we have nurses working the hotline. But it's between 15 and 20, and about 4 at a time of those are screeners. So we have 2 at the front desk, 1 down on the water side, and 1 at the express clinic. But other than that, they are fairly high wage folks. So nurses manning the hotlines. We have a provider working in the respiratory evaluation station. So these are not easy roles to fill, and it's quite a commitment.
Thank you.
So we'll move on to cash next. And here we have the days cash on hand, excluding the Medicare loan. As we knew we were paying it back, we haven't included it in here as the days cash on hand. So we're running about 118 days of cash. The big jump in July was related to the 3.7 million of 2014 through 2017 Healthcare Authority payments for our enhancement payments. Excuse me, that didn't count as revenue because we recorded it back in 2015, 16, and 17. But that was cash we received middle of July. With the Medicare loan, we're right about 170 days. So we actually have higher cash on hand than we've had for quite a while, though it took us a lot of CARES funding to maintain at these levels. Also notable in July is that we make our large biannual cash payments for the ESSB loan in July. So the impact of that is somewhat hidden because of both the enhancement payment from the Healthcare Authority, and because of you can see that AR is floating right around 44 days. The decrease from where we were in the 50s to 45 drives up those days cash on hand as well. We'll move on to the board income statement. Year to date, we are about $25,000 as a favorable variance. And part of that's related to travel, and we've also included, there's some management or some consulting fees that we budgeted for that we haven't used so far this year. And lastly, our projection for the end of, for August. So we're about 92% of budget in terms of what revenue has been recorded in this month. As of this morning, we're trending that's likely how we'll land the month, somewhere between 8 and 10% below budget. However, depending on the kind of who's on vacation, sometimes some charges can come in a little late. But we continue to see AR down 40 to 43. So I expect a tick down in AR again this month, keeping us below our goal of 45 days. Are there any questions?
Questions, anyone? Mari?
Yes, Hillary. I seem to recall in looking at the financials that in the packet that there are some, we weren't receiving the tax payments per usual. Was that correct? You know, from property taxes? Yeah,
we record the taxes when we're paid, and so since they're collected biannually, but they're
is that because they were delayed until July if people were finding hardship?
They were. So we didn't, this month we didn't receive it. I don't know offhand. I will follow up.
I was just curious as to why. Yeah, we didn't receive. It looks like we didn't receive the tax payments to support our bond and also our maintenance taxes.
Yeah, I will circle back with you and if appropriate.
Yeah, just curious.
Yeah.
No big deal, because I think we've got a little bit in the bank right now.
Yeah.
Anyone else? Well, I think it's amazing that we're 91.7% of budget in this time.
Mm-hmm.
That is truly amazing, and kudos to all of you, your whole team for achieving that. So if there's no further questions, then thank you, Hillary, for your report, and we'll go on to board business. And I know you had some information that you wanted to share with us, Case, and also we wanted just a brief update on the health equity report.
Sure, thank you, Jill. First of all, in terms of the health equity report, Bruce and I have been waiting for the draft that's being put together by the Board of Health. They, or I should say we, have created a draft that has been extensively reviewed by people of color in this community, and we've been getting some feedback, and we're in the final stages of making that a document that we can share, that we can adopt at our Board of Health meeting in September. And then I would, anyway, and so it'll become public at that time. I would like to read just one quote that will be in that report, which I did send to my fellow commissioners last week. And it's a quote by the great civil rights leader John Lewis, who passed away on July 17th. And on the day of his funeral, the following essay was published. Quote, "Like so many young people today, I am searching for a way out, or some might say a way in. And then I heard the voice of Dr. Martin Luther King Jr. on an old radio. He was talking about the philosophy and discipline of nonviolence. He said we are all complicit when we tolerate injustice. He said it is not enough to say it will get better by and by. He said each of us has a moral obligation to stand up, and speak out. When you see something that is not right, you must say something. You must do something. Democracy is not a state, it is an act. And each generation must do its part to help build what we called the beloved community, a nation and world society at peace with itself." So as soon as that draft from the Board of Health is far enough along, Bruce McComas and I will look at it and start working on it, and hopefully we'll have a draft to share with this board at our September meeting. And then just a few quick comments about my work with the Board of Health related to COVID-19. First of all, just to let people know that if you go to the county website and you look for case information, there's now a new listing at the end of the list of all the cases posted. And it's the number of cases that have been, the number of new cases that have been confirmed in the previous 2 weeks. And this is currently thought to be the best sort of rolling number to see how we're doing, because a day-to-day fluctuation in number of cases is not very helpful. And the current is 37 per 100,000 population in the last 2 weeks, and that's still within the range of doing fairly well, and actually is still within the range that we can all hope that our local school districts will be able to have some in-person classes, which I think parents are desperately looking for. And then the other thing is that by far the cause for local transmission is not the tourists, as had been feared by many people in this community. It's the quarantine fatigue of our own residents here in Jefferson County. And so the goal for each one of us should be to avoid being on anyone else's contact list, because the contact tracers that are looking for suspected contacts of people who have proven to be positive are on call 24/7, and you don't want them knocking on your door because you've haven't followed the appropriate procedures. And so once again, just to thank the tremendous collaborative relationship between this public hospital district and our public health department.
Okay, thank you, Case, for that update. Is there anyone else who has anything, any board business? Mari?
Yes, it is board business to the extent that I'm a member of the board and a former employee of Jefferson Healthcare. And I just want everybody, whoever it is, at what level you work, what job you do, all the employees, the directors, the leaders, Mike, Glenn, SLG, the tremendous work you've all been doing, and the fact that, we thought this was going to be, maybe a few weeks or a month or two, or it's now 5 months in, and the stress must be enormous. And as a former employee and a board member, kudos to you all, because you are doing sterling work, and some days it must be hard to come to work. But as from my point of view and from the point of view of the community you all serve, thank you so very, very much from the bottom of my heart. And especially Mike Glenn, because Mike is the puppeteer in all this, taking us all through it and supporting I hope our Jefferson Healthcare community to be as good as we are and as better than most. Thank you all.
Well said, Maury. Well said. Matt, do you have any board business?
I don't think I have anything today.
How about you, Bruce?
No board business now.
Okay. Mike, do you have anything, any comments or anything that you'd like to say?
Nope, I'm all good. Thank you.
Okay, then we will go down to our meeting evaluation. And Maury, you're at the Brady Bunch top left, so
Well, all I can say is nice to see Matt and Case and yourself. If not in person, at least virtual, not just the voice. So I think it worked very well today. Great information. And, the fact we've got the new CT scanner and all the other positive things that are going on, and Brandy being wanting to be at the top of the show and getting this DMV to come back in the middle of all this work that they're all doing. Terrific. So thank you all.
hey, Matt?
Yeah, I thought it was a great meeting. Tons of great information, and yeah, I want to say, Jill, you've done a great job in converting us to online commission meetings, and I think the video is a great. This platform is working perfect now.
Yeah.
So
Great. Thank you.
great job.
Bruce?
Yeah, I mean, I would agree with what both Maury and Matt have said. Is that I mean, there are always good meetings with just a ton of good information and great reports, and it just emphasizes the great job that everybody at Jefferson Healthcare is doing. And I mean, compared to, like Maury said, most of the counties in the state and certainly in the country, I mean, what we're seeing doesn't just happen. It's through a lot of hard work from the hospital and the public health department and the citizens doing their best in most cases to comply with with the guidelines. So
yeah.
Case?
Yes, it sounds like we're reaching consensus on how good this meeting was. I would also like to thank Alyssa Rodriguez for her phenomenal support for some of us Luddites learning to use new technologies, and look forward to our meetings.
Mike, would you like to comment on the meeting?
Well, I thought it was a great meeting. I think this platform is effective as well, and I'm glad it's working for you. And just a final announcement with respect to Alyssa, and I'm going to steal her thunder a little bit, but Alyssa has accepted a job with Human Resources. So she is going to be advancing her career and actually be involved in important meetings, and not just because she's the administrative assistant of the hospital or the administrator. So I could not be happier for her. I'm going to miss her a great deal, but I think it's a great step for her, and I'm really pleased, and she's going to help with the transition to the extent that's necessary.
Mike, does that require board approval, by the way?
She probably wouldn't get it. I mean,
yeah, right.
Really, no, we don't want you to go anywhere. We like you too much.
Well, I have definitely enjoyed working with all of you it's been 4 years now, which is crazy to me, but I've learned so much, and you guys have been great, and hopefully I can continue to help out while we do this transition.
Thank you, Alyssa. Thanks for
Alyssa.
all the hard work you've done.
Congratulations.
I just got her so well trained, and now doggone.
I know. I feel the same way.
However, I must say that I appreciate this organization in supporting those who are looking for some kind of advancement in their careers and in their skills. And so I think that's a tribute to people wanting to continue to work with our staff and are supporting them adequately. So thank you, Mike.
No, sure.
Absolutely. And I agree with all of you. So I think we had a great meeting and I really like this platform. So I
have one comment
see.
about the platform, and this is from Case earlier on. In Zoom, you can see the gallery and see who all is on all the time. And with this platform, we can't, and it's okay, but it's I support Case and his comment on that.
So while you got, David sent me a little how-to during the meeting, so I'll forward that on to everybody.
Great.
Okay.
Great.
As long as it's not just praying to the gods, we're okay.
Okay, at this time then, we can conclude the meeting if someone will so move.
So moved.
Don't all answer at once. All right, it's been moved and seconded that we conclude. So without further ado, goodbye all. Thank you.
Thank you so much. Thank you.
Okay, we're done.
Bye.
Bye.